Good morning, everybody. At the outset, we'll thank the AIOS for giving us this opportunity to have this IC on ultra-wide field imaging. We all know that ultra-wide field imaging is now becoming more and more popular and is being incorporated into day-to-day retina practice. However, when it comes to an individual practitioner, it's difficult for him to decide which technologies to go for because there are about 4 or 5 technologies available now in market. So in the next hour or so, I and my co-instructors would discuss the various technologies we are currently using in our day-to-day practice, and maybe we can give you tips of which technology works in which way, and that would be helpful for you to make a decision of what technology to adopt in your day-to-day practice. So our aim is for this IC is to get familiar with the currently available technologies. And the first point first, what is really ultra-wide field imaging? When we talk about ultra-wide field imaging, we are talking of a single capture image centered at fovea, which captures the retinal anatomical features anterior to the vortex vein ampullae in all 4 quadrants. So we are talking of something like this, where you have all the vortex veins seen in one picture and the anatomical structures anterior to the vortex vein. So usually you should get at least 180 to 200 degrees of retina in one picture. And to compare with the present other modalities of evaluating the retina, we have this slit image, you have this direct ophthalmoscopic image, which is only 10 to 15 degrees. Then you have an indirect ophthalmoscope single image, which is about 30 degrees. And the fundus camera, the Sanders fundus camera, which takes about 45 degrees. A wide field SLO would take about 110 degrees, whereas a real ultra wide field would take somewhere around 200 degrees of image in a single capture. Now, in this course, myself, Dr. Nitin Prabhudesai, I'll be presenting mainly on the Optos Daytona technology. And my colleague, Dr. Anand Kumta, is not there at present because of some personal reasons. I'll be presenting his presentation on autofluorescence with Optos technology. Then we have Dr. Prashant Bawankole, who will be talking about the Mirante technology with NIDEC. Dr. Sharad Bomaj will be talking of Spectralis Heidelberg, and he has both machines with him, so he'll be discussing and comparing Spectralis with Optos. Dr. Deepak Bhatt, he's also not there for health reasons, so I'll be presenting his presentation on Claris by Carl Zeiss. And lastly, we'll have Dr. Vatsal Parikh or Bhishma Pidama, who will be talking on Silverstone, which is the latest technology by Optos, which combines both ultra-wide field, retinal imaging, and OCT. So briefly, we'll be looking at these newer technologies and comparing them with the existing technologies and talk about the specific advantages which you have with these technologies. Obviously, none of these technologies are cheap. There is a cost factor, which we'll also briefly discuss. And then the availability and utilization for an individual practitioner. That's our aim in this particular talk. Can I go to the next talk, please? Okay. So now, in the next few minutes, I'll be talking about the ultra-wide field imaging with Optos, mainly the color, red-free, and choroidal imaging with this technology. Now, this is the image of a device I'm talking about, the Optos Daytona. Now, the biggest change which this technology has is that there is no typical fundus camera in this. The rest 3 technologies you will be seeing, it's something of a modification of a fundus camera. But here, it is not a fundus camera. It is a device to which the patient goes. The device is quite compact. This is the iPad-like device here to enter the data. This is the CPU, and this is the screen here where you see the images instantly. Now here the patient has to go towards the device. You need an assistant, or actually it can be done without an assistant also, because this is a small chart. In the center you see a green color object, above that is a blue color, and below that is a red color. So the patient himself sees this object. When he sees it blue, that means he is a little far off. He has to go a little bit forward. And when it is red, he is too closer to the device, so he has to go a little back. And when he sees the green, that's it. Immediately there is an auto capture, and the image is grasped. And within a second, you will see this image on your screen. So it is like do-it-yourself device almost. So you can keep it in kiosks also and have the patient's retinal imaged. Only thing is the cost. Now, how does it work? Basically, there is an ellipsoid image mirror inside with two focal points. The first focal point acts as a pathway for the laser to focus on the retina, whereas second focal point allows a coincidental focusing of the patient's eye. So you get a resolution of about 20 microns on axis and 40 microns off axis. Now you'll see in the images as they follow that you'll see a green and red tinge. Why does that occur? This is because two lasers are utilized. One is a green laser of 532 nanometers and the other is a red laser of 635 nanometers. The machine enhances the retinal image using these two laser wavelengths to magnify and separate the different layers into color components. The overline green and red images are created. The green penetrates the upper layers of the retina, whereas the red penetrates the deeper layers. The images captured are about 200 degrees at one go because the scan point is posterior to the iris plane. The virtual point acts like a pivot around which a large screening angle is possible. So it is like imaging the eye from inside the eye. So this is, as you can see here, this is the pivotal point just at the plane behind the iris, and a whole area is available to scan from inside the eye. So in short, the key benefits are a 200 degrees or almost 80% of retinal view in one go through an undilated pupil, and that's very important. You can get it through almost 2 mm pupil also. Almost instant display on the monitor screen, so you don't have to wait for the images to get developed and other things. And the software gives you red and free choroidal images. Once the red image is there, the basic image is there, you can toggle with the software and immediately see the red free and choroidal images. There is cloud storage, so there is no usually problem with data storage. And most important, it reduces the in and out time of the patient. So this is a normal image you would get. You can see there's a reddish, greenish and reddish hue, but over the period of time you get used to it and there is no problem with detection. This is a red free, just by a click of the software, and this is the choroidal, and this is an autofluorescence. You have to take one more image for autofluorescence. This is an autofluorescent image, and see the resolution. Even if you magnify it, there is no loss of resolution with this. Now, even after 200 degrees, if you want to still take a little bigger, in very quick sessions, you can take additional images. It takes less than a second for an image to be captured. So this is a standard straight ahead. You need to take an upper gauge image to see the upper periphery, the lower gauge image to see the lower periphery, the left image and the right image, and then you can collage it or montage it, and you get this whole image of montage of all the 5 images. And if you compare in between, as you can see here, in this one single straight 200 degrees, you can see this vessel here is branching, but if you go to this, you can still see further down. So this can be increased from 200 degrees to about 230, 240 degrees with the montaging of the images, which also takes a very short time. As you can see that most of the images, there may be some blashes seen, which is a problem in according to some other technologies. But if the eye is little larger, like this myopic eye, and if you just make a little bit of holding of the lid, you can get this montage image absolutely lashless and from edge to edge, especially in the temporal plane. Now, you can use this peripheral modes to document your inferior, like you have a small atrophic breaks with a snail track degeneration, very well seen in this and very well captured. Peripheral breaks, like this is large SST with a fluid component, you can see that and document it very well. If there's a retinal detachment, you can see these peripheral breaks and document them. Post-op, first day, very clear image. You can see that there is a good buccal edge. The breaks are well on the break with some early cryo reaction, a gas bubble in the eye, and the same eye after 1 month, very nicely seen that the retina is nicely attached and there's no other complication. Now, just to compare, this is my own patient. I have a Topcon camera for autofluorescence and for fluorescent angiography. Now, this Optos Daytona comes with fluorescein as well as ICG models also, but they are fairly costly, so I didn't go for it. But for my basic FFA, I use this Topcon. Now, this patient with minimal cataract, see the quality of the Topcon image, the central field, and the FFA, which showed clearly that there is an NVD. But as you can see in the color images, this was not very prominently seen. There's some venous looping here seen, but rest of the things are not very clear. As compared to that same patient immediately done with Optos, you can see there's cortical cataracts, you can see them very well, and a lot of changes seen in the retina. You just magnify a bit, you can see this NVD, venous loops, and you just go to the red free, you can see the NVD very well. So actually you don't need an FFA also if you get a picture like this to confirm the presence of NVD. As you can see, the images show very clearly the extent of hemorrhages to their end. And again, if you magnify those images, all these changes of PDR like NVD, IRMA, of peripheral NVE, venous loops, all can be very well seen and documented. Also, if you have a break, which you saw before, we did a laser to it, and you can very well document how good the images can be captured. Sometimes it is useful practically. So this patient had multiple lattices. I wanted to do laser, but was very uncooperative. So we had to stop. But I felt that some of the areas were not fully treated. So I took an image immediately, and we could see that this area of the retina still has a small break and some small fluid. So we can document this and show to the patient, and next day called her back for treatment. So it can be very helpful in patients who are not very cooperative. And as you can see, if you go to the red-free imaging, you can see NVs are very well seen. So in patients who are not cooperative for FFA or patients who are not fit for FFA, you can do this imaging and document it so that you can go ahead with the laser without the FFA. You can see that NVE very well. And also macular changes can be very well seen. This is Cellophane maculopathy, a lamellar macular hole. And this patient who had undergone a laser for branch veil occlusion with new vessels, but the new vessels were persisting here. So we did an anti-VEGF injection, and within a month, when we did the imaging again, you could see that the vessels have regressed. So it can be very helpful in documenting and following up the patient who are under your treatment. And the third part of it is the choroidal imaging, where it helps in assisting demarcating the choroidal detachments. You can even see the burns, laser burns which were done earlier, and it also highlights the choroidal sclerosis. We'll see some examples. This is a choroidal detachment in the early post-op period of a case with, which had undergone trabeculectomy. Laser burns, you can see these laser burns are done 10 years ago, but you can very well see them, and we know where exactly the burns were given and whether there is need for additional laser. Or if a PRP has been done, you can see the skip areas, and you can decide whether additional laser is to be done, which areas you are going to treat. Choroidal tears can be very well denoted by this particular imaging. Now, this is a case of choroidal sclerosis. On color photography, it's not very prominent, but if you go into choroidal imaging, you can see that these are very prominently seen, and you know why the patient would not improve in his near vision. Now, we can do the image comparison in the pre and post-op periods. Pre-op, this is a young diabetic with extensive TRD involving and tractioning the fovea, underwent surgery, and post-surgery you can see there's silicone oil in the eye, the foveal traction has gone, and all the membranes have gone. So you can keep following this patient. Patients like this is a patient who has undergone scleral buckle in one eye and lattice region treated in the other eye with laser. You can follow up and serially see over the years how they are behaving. Is there any new change? It can be compared with the earlier images. Even for routine patients who have cataract, you can see very well, you can place these two images in front of the patient and show him that one eye, there is blurring of vision because of this dense cataract in the center, other eye is clear. Or this patient of narrow angles who also had diabetes. So we couldn't dilate her, but we did an Optos imaging, and we could show it to her that she has maculopathy also. So post treatment of her narrow angles, we need to treat the maculopathy, which when we explained to the patient in the beginning itself. It is very useful for pediatric patients. As you can see that when we take pediatric patients for treatment, dilatation becomes a problem. They don't allow you to put drops, and if you put drops, they get dilated. They don't allow you to examine. They keep moving, they keep dancing. So in these patients, if you explain them that this is a toy which they can play, they have to just look at a light, and they are very cooperative, and you can get very good retinal images of such younger patients also. So the advantage is that we have a comprehensive eye care which can be delivered swiftly without any compromise on the quality. And in special situations like patients who are intolerant to light, patients who don't want post-dilated light problems if you have dry back home, especially in the night, uncooperative children, patients who have contraindications for FFA like pregnant patients, patients with renal failure, patients who had past allergy of FFA or who just refuse FFA. all the suspected narrow angles, and patients who have probable allergy to dilating drops. So the device-wise auto capture mode allows image capturing effortlessly. There are no moving parts. That's very important. As you can see, the patient has to go to the machine. The machine doesn't move at all. So no moving part, hence patient positioning is easy. And the staff can be trained very easily. It's a very simple procedure. Any person with basic IQ can operate this. And other advantages that if you're not in the clinic and staff can take the image and send it to you anywhere where you are, even on WhatsApp, and you can at least attend the basic problems of the patient. So in conclusion, Optos Daytona is an ultra-wide field imaging technology which I think should become more and more popular. It allows comprehensive eye care without any compromise. And once I think cheaper options of this type of similar technology is available, it can be a common instrument in all the ophthalmologist office as we have autorefractors at present. Thank you for your patient hearing. We'll take quick questions per talk, and then we have a good time for discussion. We'll go to the third one now. My friend Dr. Anand Kumta was not able to come because of some personal reasons, so I'll be presenting his talk. This is again a talk on ultra wide field autofluorescence with the same machine which I was talking about. So we'll just look at a case where a 67-year-old presented with diminished vision in both eyes for 2 years. His vision in both eyes was 618. There was no systemic illness. This was his clinical picture. He was diagnosed elsewhere to have CNVM in both eyes and treated with multiple anti-VEGF injections with poor response. You can see here that there are RP changes right at the fovea in both eyes, almost similar picture. And this is his OCT picture where you can see that there is subretinal fluid, some RP changes, intraretinal cystic changes. But if you do an FAF, you can see this is a classic CSR picture. You can see this gutter-like changes here in both eyes and spectral changes in the foveal area. So this is a CSR and not a typical CNVM. So autofluorescence allows you multiple disease entities to be characterized in a particular manner. You can have the VK edge, multifocal pigment placoid choroidopathy, melanoma, atrophies. All these have various patterns, and if you understand them well, it can help you in your day-to-day practice. So we have talked about these things. Here in the autofluorescence mode, we use the green wavelength of 532 nanometers. Now basically in autofluorescence, the lipofuscin pigment is the important pigment which is located in the RP. It is the most dominant fluorophore, and it is basically a metabolic waste of the photoreceptors. It is indicative of oxidative cellular stress, and it is increased in degenerative disorders like AMD, macular dystrophies, Best and Stargardt disease. So in all these situations, autofluorescence is important in uveitis, drug toxicities, optic nerve drusen, chronic CSRs, in choroidal nevus, macular dystrophies, RP, AMD, and in certain cases of unexplained visual loss, it will be very helpful. And now we'll be seeing some examples of all these. So basically, because ultra-wide field imaging itself allows a wide imaging of the retina. So in the picture on your left, you see that you hardly see any RP changes in this patient. But if you take an ultra-wide, you'll see that the whole of periphery shows RP changes. So it's important that you have an autofluorescence and you have an ultra-wide field autofluorescence. So typically in an autofluorescence mode, the optic nerve would look dark because there is no RP or lipofuscin there. Then the fovea center would look dark because again there are no pigments. The blood vessels look dark because there is absorption by the blood of the pigment. Then periphery looks grayish, and parafoveal area there will be mild decrease intensity because increased melanin content and lower density of lipofuscin in the central RP. So the abnormal autofluorescence is because there is a change in the amount of composition of fluorophores in the RP cell cytoplasm, and there is absorbing or autofluorescent material anterior to the RP. So we have a term called hypoautofluorescence, which are dark areas, and hyperautofluorescence, which are bright areas. So if there is hypoautofluorescence, that means the RP are dead, and you can get a typical dark, punched out dark area of hypoautofluorescence, or there is blood absorbed signal because of interference by blood, pigment, or another blocking artifact. So if you have an RP atrophy, you get this picture. Laser scars will look like this. And if there is hemorrhage blocking the retina, you will see again a dark hypoautofluorescent patch. Drusen's will different forms of Drusen's. Hard Drusen's will be where there is RP atrophy associated with it. You'll get dark hypoautofluorescent areas. Exudative lesions again will produce a dark areas. And if there is dense hyperpigmentation, again you'll get dark areas. So basically, if there is hyperautofluorescence, that means there is excessive lipofuscin, and that indicates sick or increased activity of the RPE. So here you have yellow lesions which will look hyperautofluorescent. Soft drusen's usually look hyperautofluorescent. Bullseye maculopathy, very typical. Center will be hypo and a peripheral ring of hyperautofluorescence. And old hemorrhages which are organized will become hyperautofluorescent. So in short, dark is dead and bright is sick or increased metabolic activity. In posterior uveitis, it is very useful because in an active stage, you will see that there is a margin of hyperautofluorescence along this edge. You can see clinically also there is white areas all around. As it starts healing, some of the areas become dark and some are still white. And in heat stage, most of them become dark. So looking at this image of autofluorescence, you can see how the patient is behaving and how the uveitis is undergoing changes after your treatment. So it is highly sensitive in differentiating active versus inactive lesions. As you can see here, it looks almost inactive, but this area here shows some activity which is seen very well on the AF image, where this area is hyperautofluorescent, indicating there is still some activity here, whereas rest of the areas is dead RP. Similarly, here some areas are healed, some are still active. You can see this by the whitish areas, hyperautofluorescent areas mixed with the hypoautofluorescent areas. Whereas later on, it is all hypo, there is no hyperautofluorescence, indicating that it is resolved. Like in cases like Medusa, you can see that multiple hyperautofluorescent spots, and after 6 weeks without any treatment, it has cleared up. Similarly, here the lesions in a active stage, you hardly see any lesions, but if you do an autofluorescent, you will see many areas of hyperautofluorescent indicating activity. And again here, clinically not much seen, but here you can see an extensive areas of hyperautofluorescence indicating the inflammatory areas. So in VKH also it is helpful because here again this area almost looks normal, but on autofluorescent you can see it's an hyperautofluorescent and total area can be delineated where there is activity, and which over the period of time heals, and after resolution it is almost cleared up. Similarly, in this case, extensive hyperautofluorescence is seen, which clears up after resolution with your treatment. It is very useful in determining optic nerve head drusen's. As you can see here, in the here you can just see a bumpy disc suspect, but here it is very clear that there is no doubt that there is optic nerve head drusen, and it helps in differentiating from in pseudo papilledema. As you can see here, this is a true papilledema, and this is a pseudo papilledema due to the optic nerve head drusen's, again seen here very clearly. In cases of drug toxicity also it is helpful because in color images drug toxicity changes are sometimes missed, but if you do an hypertension you can get a typical bullseye maculopathy with a central hypo surrounded by an hyperautofluorescent ring. So in cases of drug toxicity like in hydroxychloroquine, didanosine, thyroidazone, teferoxamine and tamoxifen, all these conditions you can see this bullseye maculopathy, which helps you determining whether the patient is reacting to it or not. And you can compare it with OCTs also. As you can see the changes here in OCT, and in autofluorescence you can see them much better. Again, if there is a distorted vision for 2 months, vision is low and patient is on tamoxifen for 5 years, you do an FAF and it can be very clearly seen. In cases of CSR also it is very helpful because the dark granular area is indicating serous leak and hyperautofluorescence seen, and you can see a typical tracks here which are very classical of chronic CSR. If you have bilateral chronic CSR, clinically you don't see much changes, but if you do an autofluorescent image, you can see very well that there is extensive changes in the RPE. Similarly, in this you can see the tract which is not clinically seen, but with hyperautofluorescence you can see the extent of the changes. In ARMD again, clinically you see very fine changes in the center, but with autofluorescence you can see the extent of the changes because of dry AMD. It helps in indicating the geographic atrophic areas also very well. And along with this, you can see the dense areas which are totally gone, whereas rest of the areas are unhealthy, and see the extent how big it is. So you can differentiate into various types of hyperautofluorescent images based on the characteristic reticular, branching, fine granular, trickling, and GPS. Geographic atrophy also helps in larger areas of the central macula being involved. We can exactly mark out how much atrophy has occurred. And if you have an hyperautofluorescent margin to it, you know that this is going to progress. In retinal dystrophies also, you can use this to exactly see what changes are, right? You can see there's a hypo in the center with a surrounding rim of hyperautofluorescence, like a bullseye maculopathy. And in this, some certain patients, like this patient of 56-year-old male, where there's a diminution of vision in the bright illumination and difficulty in color appreciation, you do an autofluorescence image, you can see the bullseye maculopathy very well. In Best dystrophy, you can determine the various stages. Now, this is a vitreoeruptive where you have some areas of hypo and some areas of hyper. Whereas in the vitelliform, you can see a typical white lesion as a moon sign, which is indicative of this particular stage. In Best dystrophies, again, when in a healing stage, you can see there is a hyperautofluorescence ring to the hypoautofluorescent center. In pattern dystrophy, similarly, you can see an hyperautofluorescent center. And you can see the changes. One eye has hyper and other eye is now going into hypo stage. Similarly, for butterflies, pattern dystrophy, you can make it out very well, which is clinically not very well seen. Stargardts, clinically you hardly see any changes, but here you can see them very well. And over the period of time, they from hyper auto, they go into hypoautofluorescence. Similarly, in retinitis pigmentosa, you can document the changes. Clinically, you see the typical bone spicule, but you can see the extent in autofluorescence. Extensive damage, only the central field is remaining, so you know that the patient has tubular vision only. Again, vision may be good, but extensive changes may be seen on autofluorescent imaging. Similarly, here, extensive changes. It will also helpful in cases of paravenous pigmentation, where you can make out this pattern very well, which clinically is not very well seen. Other very important application is to differentiate between the choroidal nevus, a congenital hypertrophy of retinal pigment epithelium, and choroidal melanoma. So, in choroidal nevus, as you can see, if you do an autofluorescence, the nevus lesion would disappear because it is below the RPE. In congenital hypertrophy of the retinal pigment epithelium, you'll see it more prominently seen. It becomes hypoautofluorescent because the RP is dead there. And in choroidal melanoma, you can see that the drusen-like image substances would cause hyperautofluorescence. Rest will be hypoautofluorescent. So choroidal nevus, as you can see, clinically is seen here, but it disappears on autofluorescence. And otherwise, it becomes in choroidal CHRP, it becomes more prominent hypo. And in melanoma, again, you have wherever there is deposition of lipofusion, you will see them as hyperautofluorescence. Conventional laser marks, you can see them extensively. You can differentiate them with the multi-spot laser. So you can make out what type of laser was done, whether it was adequate, whether there skip areas. So to conclude, I think if you are doing a retinal evaluation and if you have this technology, it is very important that you should screen most of the patients with this, because it gives you a lot of information which is not clinically seen. And it tells you the metabolic state and overall health of the RP and allows detection and analysis of many pathological and retinal conditions with peripheral findings. Assessment and progression of follow-up of many retinal conditions is possible, and lot of conditions which are clinically invisible become visible with FAF. Thank you for your patient hearing. So I have completed 2 talks, and now I would ask my friend Prashant is there? I think Sharad, you can go ahead with the presentation. Dr. Sharad Bohmat's presentation. If you have any questions, we can take it now also and maybe in the panel discussion.
So I'll be talking about comparison of retinal imaging with Heidelberg and Optos versus what are the advantages and disadvantages. So first of the multimodal imaging is the color fundus photography. Now, as has been, you have seen these beautiful images of the Optos. There is no comparison to the Optos technology and Heidelberg as far as color imaging is concerned. Especially if the lesions are peripheral, they are elevated. You cannot have any other system like Optos to capture the wide field imaging of the color fundus. If you have hemorrhage, you have panoramic view of the fundus incomparable with the Optos. Documentation is extremely useful with the Optos. You can't compare with any other technology. But it can miss some findings in the periphery. So indirect ophthalmoscopy with scleral indentation remains the most reliable. But if you want a panoramic view of the fundus examination in an undilated pupil or in an uncooperative patient, so this is the technology for you. You can see the entire fundus without dilating the pupil. So it is extremely useful for screening the patients and documenting your findings of the peripheral fundus. It's the greatest tool available. So now color imaging, fundus color imaging with the Heidelberg spectralis. So basically this machine comes with three lenses. One is a 30-degree lens, basically meant for the posterior pole, 55-degree lens which is going up to the equator, and you have got an ultra wide field lens that is 102 degrees. So the color imaging is possible only with the 30 and 55. With the ultra wide field 102 imaging, it is not possible. So this is the 55-degree image. Because of this laser technology, you get very accurate representation of the undulations in the surface of the retina. So you can see very finely all the changes, but they are not very great, the 55-degree color images. So what is the technology of multicolor imaging? It comes in its element basically with the 30-degree lens, central lens. So very fine macular changes are documented and highlighted so fantastically with this multicolor imaging that very fine things you can pick up with this 30-degree lens multicolor imaging. So I will show you this particular image with the multicolor central. You can see every striation seen at the macula, whereas it's not very great with the Optos. There is some loss of resolution for the macular imaging compared to the 30-degree multicolor imaging. So then some very subtle changes which can be there. Now this is a case of parafoveal telangiectasia. Even the naked eye cannot pick up these very subtle findings in the early stages. In the advanced stages, obviously you will see the classical perifoveal halo and other things. So this is a early stage of parafoveal telangiectasia, and you can see the multicolor imaging picks up this perifoveal gray. It will tell you that there is definitely something abnormal. You correlate with other multimodal imaging technique like OCT, you will not miss the diagnosis. The same patient seen on a Optos, because it is basically designed to get a panoramic view of the fundus, you can miss very minor details of the macula. Not in every case, but in some of the cases you may not. Now other thing is in a dense, if you have a cataract, so in a cataract the macular imaging with the multicolor of the Heidelberg spectralis is amazing. So you can see, you cannot see much with the Optos image, but with the multicolor image you can see all the fine wrinkling appearance of the macula in the posterior pole scan, and this is corroborated with the OCT. You can see very fine, everything can be seen, every detail undulation of the retina can be seen in the posterior pole. This is a case of dissociated optic nerve fiber layer, where it is very easily documented with the multicolor imaging, whereas these details cannot be that properly highlighted with the Optos imaging. So basically very fine details of the posterior pole, you can have some additional advantages with the multicolor imaging of the posterior pole. Is another example of a suspected disc edema. Even with the naked eye, it was a bit difficult to know whether their disc was really elevated or no. So you can see with the Optos image of the same patient, you can see something, but you don't know whether the disc is a normal variation or it is abnormal. But with the multicolor imaging, you can see that the bottom, compare it with the normal fellow eye, you can see it's highlighted so well, you know that there is a disc edema that you cannot pick up even with the naked eye. So, as far as the posterior pole imaging, the multicolor imaging has got some advantages over the other technologies. But I would say that the same image with the traditional color fundus photograph and the Optos image, you can see side by side the finest imaging details of the fundus of the posterior pole are still the best with the traditional fundus camera. So still it remains a gold standard for posterior pole imaging, the traditional fundus camera. Now we have to give printouts to the patient, and again this Heidelberg technology, especially if you want to give some pathologies of the macula and other things, you give very wonderful printouts, and you can highlight all the pathologies very nicely. So you can see this case of macular BRVO. You can see the very nice imaging of the posterior pole, and the combination with the OCT printout looks very nice. And this is a heredomacular degeneration on the right side. Again, you can see very nice area of the central atrophy, the autofluorescence which is there side by side, and the OCT image. So to give the printout of the patient, they look very nice, and you are able to give what you have documented on your fundus imaging system even to the patient as a printout. Otherwise, many technologies, they look very good on the computer, but you cannot give good quality printouts to the patient. So with this, the additional advantage is that the quality of the printouts are really good. So as compared to the Optos, not great quality of printouts, but they are decent but not great. Now, some additional features are there with the Heidelberg technology, which is the infrared imaging. So, some of the pathologies like the retinoschisis or some pathologies in the mid-peripheral fundus are highlighted very nicely with the infrared imaging because of the laser technology. This kind of imaging is very accurate. So for follow-up of the progression of the schisis and some of the peripheral lesions, even though it is a black and white image, you can have a very nice detailed view of this and follow up in the periphery. Now this infrared imaging is very useful even for the OCT, because the kind of printout which you can, the kind of image which you have of the infrared fundus, you can have very accurate documentation from where the scan is passing through the fundus. So this is a very important addition to the OCT technology, the infrared imaging of the fundus. Now coming to autofluorescence imaging, comparison between the Heidelberg and the Optos, there is no comparison for wide field autofluorescence because the spectralis is not designed for wide field autofluorescence imaging. So where you want wide field autofluorescence imaging, Optos, there is no comparison. It does fantastic. But when you come to the posterior pole again, to document very fine details, again it is a slightly superior to the Optos imaging because of the blue pleaked autofluorescence. So it makes the hypoautofluorescent lesions and the hyperautofluorescent regions much more contrast. So it is a gold standard for imaging for dry AMD and geographic atrophy, especially in clinical trials. We have got many technologies coming for the treatment of dry AMD. So for posterior pole autofluorescence imaging, the spectralis Heidelberg has got some edge. So this, you can see a progression of the geographic atrophy very highly highlighted. Now the next technology which we compare, modality which we compare, is the fluorescein ICG angiography, Heidelberg versus Optos. Now basically the Optos, definitely on the right side you can see it gives a very wide imaging of the fundus compared to the Heidelberg technology. But with the 102 degrees lens which you have with the Heidelberg, you get better superior and inferior quadrant, that is a vertical meridians you can see wider than the Optos because of the lashes and the eyelids. The imaging with the in the superior and inferior quadrants is slightly wider, and whatever picture you get is slightly better quality than the Optos. Now there is no comparison for the single shot image of a fluorescein or a ICG angiogram with the Optos. With a single shot, you can see a very panoramic view, and you can highlight the pathology in each phase, entirely what is happening through the entire fundus. That's the strength of this technology, Optos. But you can do some adjustments with your Heidelberg machine. There is something called as steering. So you ask the patient to slightly move the eye, and because this machine can be swiveled, it allows you to capture very beautiful images even of the periphery. Obviously you will not reach the aura, but you can have quite anterior views. So you can see a comparison, a single shot view with the Optos and a steered Heidelberg image. You are able to capture all the details what the Optos is imaging. So this is the case of PHCR, peripheral exudative hemorrhagic choroidopathy, and this is a ICG angiogram steered view with the Heidelberg. You can see all the polyps, and you will not miss any findings even with the Heidelberg with the steered images, beautiful images. So this is a case of vasculitis. Again, you can see with the steered image, you are able to capture the peripheral fluorescent angiographic features of the fundus very nicely, and it is as good as the Optos, only you have to have steered images, not a single shot straight ahead image. So the next modality which we want to compare is the OCT, Heidelberg versus Optos. Now at the outset, the OCTA technology is still not available, but it will be available in the Optos. So, but right now the OCTA technology is not available. But the advantage with the Optos technology for the OCT is that anywhere in the fundus you can take your cursor and view the OCT sections of any part of the fundus. That's a very huge advantage. May not relevant for day-to-day practice that much, but for research and other purposes, it's extremely useful. So if you can see the Optos OCT going to the periphery, the schisis has been, you can take a section of the OCT anywhere you want and document the vitreoretinal interface findings. In the periphery of the fundus, distinction between a hole or a cyst and such things can be advantageous even for the clinical scenario. So this kind of imaging is not possible with any other technology, only with the Optos. But where the Heidelberg OCT scores is that the kind of reliability which it can give you with the combination of manual joystick operated steered images, ability to move the fundus camera, so it gives you some special advantages, and complemented that with the live tracking. And because of the live tracking, very reliable serial comparison of the same images of the same patients over time, which is extremely important, especially in wet AMD, glaucoma, all those things. The serial comparison of the each image and documentation because of the live tracking is extremely important. Because it is so accurate, there is a documentation of the vascular pattern of the fundus of the patient, and that will be compared and with the every time. So you will have the same scan at the same point of each time. Then it is unmatched reliability and resolution for retina and glaucoma scans. So you have got a very good normative database, you have excellent glaucoma premium modules and other things. So it makes a very reliable technology for your routine OCT technology. Then Octa, as I said, is not available with the yet available with the Optos, and obviously anterior segment imaging is also not yet available with the Optos. Whereas in the Heidelberg, you can do the cornea imaging, the angle imaging, all these things can be done even with the Heidelberg. So some advantages like OCTA and anterior segment imaging with the OCT is possible, but not possible as of now with the Optos technology. Both technologies are extremely excellent, but you should know some limitations will be there for each technology, and there are strengths of each technology, and they have to be put in perspective and utilized in that particular way. So Optos is unmatched for multimodal ultra wide field imaging. Anything you go in the peripheral fundus, there is no technology which can give you a multimodal imaging with that accuracy and quality. So and but it doesn't have the OCTA as that, and very minute macular pathology can be missed sometimes with the Optos because it is designed for a panoramic view of the fundus. The spectralis is also a very wonderful multimodal imaging, but color photography is absent. So you will need a color imaging device because there is no color fundus imaging. Multicolor imaging is available. It has got advantages which I have highlighted in the presentation. But if you ask what should be go, and most of us will be already having a traditional fundus camera, and it still retains its place in the armamentarium of a retinal surgeon for the multimodal imaging, and the traditional fundus camera still is very useful for posterior pole and traditional um, 100-degree imaging. So you don't throw your fundus camera out. You can, if you combine the Optos Daytona for color imaging, autofluorescence, spectralis for wonderful OCT and angiographic images, and the traditional fundus camera for good color fundus photography, it makes a complete multimodal imaging system for your clinic, because you're not relying only on one machine. If one machine breaks down, you have something to rely on. If you put all eggs in one basket, if one machine breaks down, then you can have problems. Thank you.
Presentation 5, please. So we have just now seen Optos and very brilliant presentation by Dr. Bomas on comparison of Optos and Heidelberg. But the last line he's told you is very important, that you should have a fundus camera, you should have an Aptos, and you should have an spectralis. So that makes your clinic complete. And I'll add one more thing now, and that is the Claris from Zeiss. This is a presentation by Dr. Deepak Bhatt, which I'll be presenting to you shortly. So what is the difference between Claris, Optos and other things? Like I said earlier, Claris is a sort of a modification of the typical fundus camera, and Optos is a totally different, like I said, do-it-yourself technology. Now the main difference between these two technologies, that is Optos, Spectralis, which use lasers, which we call as scanning laser ophthalmoscopes. Here they have changed, Zeiss has changed this technology, and they're using broad line technology, where there is sequential illumination of a broad spectrum of red, green and blue diodes. So they are not using lasers, but they are using diodes. This generates image with high dynamic range, contrast and resolution, and most important, natural colors. So their USP in getting Claris is to get almost like Dr. Boma said, you have to have a fundus camera to get the typical color fundus picture as you nearly see with your eyes. So this is what they are trying to maintain, an ultra wide field imaging with near natural colors. So this is what they do, is they have a broad line technology, and this is image type quality you get with the Claris. This is a 135-degree single shot image centered at fovea. And look at the colors, that's what their USPs, that they will maintain near normal colors. And obviously the resolution is very good, so you can get even a magnified view like a typical 35 degrees or 45 degrees fundus camera. And you can have 2 or 4 image montage in this, which again takes a little bit more time. And mind you, taking an image with Claris is not going to be as fast as the Optos or probably even the Spectralis, but once you take the image, the quality may be very good. And as you can see, if you take 2 images, you can get a broader, more than 130, it almost goes up to 200. And if you take the 4 images, it still goes more, up to almost 230 or 240 degrees. So this is a 4 image montage, and in 4 image montage, if you have done peripheral treatment, all that can captured very well, and in the true color mode. As you can see, this extensive laser has been done to the periphery, and that has all been well captured with this 4-point montage. And if you have peripheral lesions, again, they can be compared very well, and they can be documented very well. Now, if you have a large tear or a large granuloma, which is seen here on B-scan, Dr. Bhatt is an imaging specialist, so he has added those B-scan images. So you can see that there's a large lesion which can be very well seen and documented, and the colors are very well maintained. In cases of neuroretinitis, again, excellent images can be gathered, and even if you magnify them, there is no loss of resolution. Now it has autofluorescence in two modes, as with spectral is the green mode and uh, the blue mode. So the green mode is more for the superficial layers and the blue for a little deeper layers. And if you want to see the changes in the optic disc, you would use the blue mode. So this is how you get those autofluorescent images. And this is a green. And in cases of choroiditis, you can see the extent of the lesions, which is very well documented by this two image pattern. You can also do an overlay with, if you have technologies of Zeiss together, if you have an Zeiss OCT and if you have Zeiss Claris, you have a software which can mix all these images and you can get a combined, and as you can see here, you can create overlays and check with OCT-A also. As a high myope, we can have a good image taken with this particular system. And as I said, we can have multimodal imaging of the retina, but not with a single device. You can have what is mentioned as synchronization. So you can have these images taken, and with one single software, you can combine them and look at them simultaneously. Now, this is a dry RMD drusen where you can take a sort of a short video and see where it is going, and accordingly you can compare it with the OCT. Now, if you have peripheral vascular malformations, as you can see here, there is a vascular malformation here, which is highlighted in this magnified view, and you can see the OCT-A image here. So this image in the periphery can be then magnified and seen, and you can have an OCT-A of that same area, and that can be seen together. Mind you, this is not taken by the same apparatus, it is taken by two different apparatus. But the software can get them together and you can have a correlation. Similarly for NVD, we can see that very well because of overlay. In case of choroiditis, again, FAF imaging, not very well seen in this color image, but very well documented with the FAF imaging. Similarly, for the central part, areas which can be then overlaid with angio, and we can compare the ischemic areas with what we see clinically. And similarly, for cases of Fuchs spots, you can see this changes here in the center, which can be overlay. You can have an OCT-A overlay on it, and you can make out the new vessels. Also, in cases of paravenous choroidal atrophy, you can see this very well documented, and you can have all three images together and compare. So in short, Claris gives the biggest USP of Claris is that it gives you a wide field near normal color imaging, which is not possible with the other two devices. So if one has to have a documentation which are used to, maybe you can look at Claris, but definitely, as Dr. Bomaja said, if you just want to look at the ultra wide field imaging, Optus gives you the best of the imaging. I'll now ask Dr. Vatsal Parekh, who has the device which combines both ultrawide field imaging and ultrawide field OCT, to give his talk.
Good morning. I thank AIOC and Dr. Nitin Prabhudesai to share my experience with this technology of Silverstone machine, which has what you have in Daytona, like ultra wide field imaging with autofluorescence, with ultra wide field FFA ICG, and image guided swap source OCT. Now, normal OCTs which we all are using are spectral domain, and this is a swap source OCT. The beauty of this machine is that it is image guided OCT. So wherever your image is located on the ultra wide field view, you can get OCT of that area, and it is a swap source. So I'll show you how we have used it in clinical application and how it has been useful. I have no financial interest in this machine. So basically, this is a useful adjunct in retinal armamentarium. It's not a must, but it's a valuable tool. I'll take you through some of the cases to show how it has been useful improving patient care. Now, this is the first photograph. This is a slit lamp photograph of a one-eyed patient with corneal opacity. You can see the cornea is quite hazy. This slit lamp biomicroscopy, you can see that probably there is optic disc here. But on ultra wide field photograph, you can see the optic disc. And beauty of this swept source imaging is that it gives you a reasonable idea that macula is good. I think with swept source technology, this is possible. So this is a valuable tool to give a reasonably good prognosis to this patient, provided you think your graft is going to do well. So I think this is a wonderful technology. Now this is a patient of proliferative diabetic retinopathy with a fibrovascular membrane here. This is a magnified view. What Dr. Sharath showed pictures of comparison of uh, Heidelberg 30-degree with Optos wide angle photograph. I think there is a difference with Heidelberg because it captures only 30-degree. But if you enlarge the Optos image, you would see the difference to be narrowed down, because magnification factor in your images were different. So what I'm showing you in this is a wide field photograph, ultra wide field photograph, where you see only this much proliferation. But if you magnify, you see it much better. So now how this OCT has helped is, here you can do OCT through this region. Now, since this is quite elevated from retina, this is the retina base RP and choroid layer, and this is the superficial part of retina, which you see inverted image, and this is the membrane here, which you can see the difference in this and this layer. So this membrane is tightly adherent here. So you can understand the plane of cleavage, and this is the vitreous attachment to this membrane here. Same patient, this is this little different area, so you can see pre-operatively how difficult it would be to dissect this membrane. And the same patient post-operative, there was a hole here because the membrane was quite attached, but rest of retina is nicely attached and patient has been benefited by surgery. So is this tool a must? Not necessarily, because you can see the same things on table. There is something called intraoperative OCT also, but I think compared to intraoperative OCT, this swept source would be much better penetration. Because right now what Zeiss gives is intraoperative OCT, which is spectral domain. So this I think would be a better evaluation pre-operative. Similarly, this is another patient of diabetic retinopathy. You can see that there are a lot of vessels here now. A beginner would confuse whether these are retinal vessels or these are new vessels, but these were new vessels. This is following eccentric injection. You can see that the new vessels have beautifully disappeared. Now again, I'm showing you ultra wide field image, which is magnified, so resolution is still good, because this is a magnified view of the area of interest. Now, when you do OCT, you realize that the retina is somewhere here, and this is the membrane what you are seeing and not retina. And I'll just show you a short clip of surgery, and it again reveals that this is the retina, this is the membrane what you are seeing. It's thicker than the retina here. So this is what membrane you are seeing, and this is the post-op photograph of the same patient. He had vitreous hemorrhage. This is the optic disc area, and retina is nicely attached. So this again is a useful adjunct in the treatment. Now this is a patient of proliferative diabetic retinopathy with traction on macula. Now this is the extent of membrane what you are seeing here, here, here. So you can do OCT at all levels wherever you want and understand the pathology. Like this photograph would be of this layer. There is a posterior vitreous detachment nicely here. So probably you can start surgery here. Whereas this area, it's tightly adherent, so it would be difficult to separate. So this gives you a fairly good idea in the pre-operative planning as to what you are dealing. Here, it's quite tightly attached here, this particular area. So this way, I think it's a beautiful technology. You can do it. Now, again, this another patient who had a sort of tabletop or plastered membrane on the retina, and I operated. And again, if you see the OCT here, this OCT, this is the retina and this is the membrane, you can't separate it. Now, when I did operate, there was a large hole and this membrane could not be totally separated. This is the best we could get. And unfortunately, patient developed redetachment, which was likely to be there. So, having pre-op OCT give us an idea as to what we are dealing with, much more than what we saw on table. Another beautiful application of this machine could be you can have a choroidal thickness or chorioretinal thickness from center to periphery up to equator, and you can study it in hyperopia, myopia, and subgroups whatever you want, and have a normative database designed, and since this is a Swapser's OCT, you can see the choroid also very well. Again, this was a patient of nevus or melanoma, and you can see the OCT can be done at different level. This was autofluorescence, and this machine has, now you can enlarge this image and see this much more, than what it was otherwise. This machine has also FFA ICG, which are ultra wide field, so it gives excellent quality of FFA and ICG. Again, you can magnify the image and see the area of interest well. There was mild staining here, and this was choroidal hyperfluorescence, the hypercyanogens there. The next biggest advantage of Swapser's technology I've found is post-op doing OCT through gas-filled eye. This was a macular hole pre-op picture you can see, and this OCT is 3 hours post-op. On the day of surgery, 3 hours post-op, you can see that there's a gas bubble. The fundus view is not clear because there's a gas bubble, but OCT is reasonably clear, and you can see the hole is closing, and day one post-op the hole was closed. Again, if you see, the fundus photos are not great. You can't make out on any other way except Swapser's that this hole is closed on day one, and this is a week later. Normally, with all our standard machines, we are able to do OCT when the bubble recedes above macula, then we are sure. But this is helpful in almost 70-80% of patients. On day one, you can do OCT of macular hole. Now, this was a patient of macular hole, and there was a peripheral break here, which would have been missed because of the absence of choroidal contrast. But on magnification, you can see the break clearly, and this patient had a small macular hole. So I think this ultra wide field technology helps. Now, this was a young patient with a macular hole and retinitis pigmentosa and abnormal vitreoretinal traction. I did localized vitrectomy, PVD induction, posterior pole, and you can see that eventually the posterior vitreous is getting detached here. So all these things are beautifully demonstrated. This was a case of retinitis. You can see the follow-up very clearly how the retinitis heals, and you can see the vitreous haze also near the retina. And also you can even in patients of choroiditis, because it's Swapser's, you can see the choroidal OCT very well. Now, Coates disease, nobody has probably defined this abnormal vitreoretinal adhesions. This is the area where OCT is taken. So I think this would give us much more insight in many pathologies. Now, this is another beautiful advantage of this machine. I have realized that this was a patient who had vitrectomy for detachment, inferior detachment. Here there was a probable inferior detachment which was picked up by OCT very well, that this retina is little elevated. Now there was an adequate gas fill in this eye, so I gave position to this patient and the retina got reattached. You can see that the same area, the retina is reattached. So this OCT helps to confirm the detachment, and since the retina reattached, I could do laser, and here this is the post laser. You can see the laser marks all round. So this helped. However, this patient detached after 6 months and had redetachment. So, but it helps to plan your treatment better. Now, again, this shows the natural course of PVR. This was another similar patient with shallow inferior detachment. Now, when you magnify this image, you see the holes here, and you can see you can do the OCT and see confirm the presence of hole. The OCT is done through this area. This is quite peripheral. So I injected little more gas, did cryo, and the patient reattached. However, it redetached, and I thought it was because of the PVR. And if you see here, this is a clinical photograph. There was a PVR membrane which has matured, and OCT shows that membrane has matured. So it helped in operating this patient again and reattaching retina. Now, this is one of the ideal case I would feel where OCT has helped. This was a horseshoe tear at ora serrata in a high myope patient whose father had bilateral giant tear operated because of myopia. But OCT done through that region showed that this is not a horseshoe tear, but this is an enclosed oral bay. And I think this was $1 million, though anyone would do laser, nothing may go wrong. But Here, this OCT which has gone through ora serrata helped us to detect that this is not a hole, but this is an enclosed oral bay. You can do OCT of many pathologies like white without pressure, lattice degeneration, and you'll have vitreoretinal adhesions, retinal thinning here. So this lattice degeneration here. Now, why this is important is sometimes these lattices are little posterior to equator. You can't indent and see whether there is hole or not. You can do slit lamp biomicroscopy, still you may not be 100% sure, but this OCT will help you to demonstrate hole if it is there. This is a subclinical RD, how it would appear. And this is a peripheral tractional detachment. You can see the traction here. So I think this technology is very good since this is SWAPSOS, it has better penetration than spectral domain OCT. Since this is image guided and SWAPSOS you can do through gas filled eye and anywhere up to equator, it allows you to understand pathology of the disease process much more. And I think this technology will help us to uncover the undiscovered lesions. Thank you for your patient hearing. Thank you.
Yeah. I now ask Dr. Prashant Bhawankole to give his talk on Mirante technology with NIDEC. That will be our last talk, and we'll have some discussion.
Thank you. So I would be speaking about the wide field imaging. In fact, this is a general presentation, not necessarily meant for the Mirante, but all these pictures have been taken with a Mirante system, which is by NIDEC, which is a wide field multimodal imaging system. So, well, if you come directly, yeah, am I able to see? It's not moving.
So by the time the images are getting loaded there, any questions from the audience? Any clarification regarding the comparison? I had mentioned about the cost. So that's an important consideration you have to give, because there is an increase at each step as you go from Optos to Spectralis to Silverstone and to Mirante. So that's one factor. So probably if you are an individual practitioner, like especially for an Optos color imaging, you leave aside the FFA and ICG. I think if a few doctors get together and buy this machine, it would be a really good thing, because as I said, for many situations like small pupils, narrow angles, people with allergies, you cannot dilate these pupil, and sometimes if the patient is diabetic, if the patient complains of flashes and floaters, you have to dilate and see these patients. Are you ready?
Yeah, I'm ready. Yeah.
So I think that's one idea you can have. If a group of doctors in a particular city buys this machine or any of these machines, it should be then become financially feasible. Otherwise, most of the time, unless you have a very large OPD, this doesn't become very productive. Yeah, Prashant, please go ahead.
Yeah, thank you. So sorry for the technical glitch. So I would be speaking basically, as I said, this is a system from NIDEC, and the model is called Mirante. Well, this is what everyone is aware. I think the initial part of the IC we have kind of covered over there, that the standard fundus photography involves retina having a visualization of the retina for about 75 to 80 degrees. But you remember the retina exists from ora to ora, that is about 220 degrees. It means our diagnosis is based upon only one third of the retinal viewing, and based on that we presume and make hypothetical diagnosis as well as the prognostication or pathogenesis of this. So these are the things what in a ETDRS you see 75 degrees, wide field if you see up to 100 degrees, ultra wide field is if you are seeing anything more than 110 to 20 degrees. So this is what you see in a conventional standard central photograph. ETDRS, this is what you see. On a wide field you can see up to 100 degrees, and this in an ultra wide field, as Dr. Parekh has beautifully shown through us. So these are the right now available options which you have in the market. These are the plus minus points which I can share you later on. Now coming to this particular feature, you have a wide field OCT. Usually the standard photograph of a OCT has only 8 to 10 or 12 millimeter beam length, while in a wide field it is at least 16 millimeter. With the Optos it is much more. I will just come to the image, clinical image. This is a 80 years mother of a pathologist who had this particular lesion. This is wide field photograph. You can see a peripheral mount over here. You can see some subretinal hemorrhage over here. And this is what you can do with a wide field image. You can play with the image. You can actually view the particular thing. And this was a peripheral PCV. We could do a wide field OCT through the lesion per se, trying to understand whether at that age it is just a melanoma or it's a PCV. The characterization can help you in picking up exactly what is happening. And then we did a wide field angio, ICGs, whatnot you can play. This is the beauty of multimodal imaging. And we treated this peripheral PCV with brolucizumab. And subsequently, you can follow this particular lesion, whether it is regressing or not, with a non-invasive technique like OCT. And you can see subsequent follow-ups, how the lesion is slowly collapsing and reducing with time. Now, coming to imaging in diabetic retinopathy is one of the commonest reason where we use. Now we'll come directly to some clinical cases. This patient had a recurrent vitreous hemorrhage following having undergone a panretinal photocoagulation elsewhere. And this is the angiogram which the patient brought to us. So what do you see? You hardly see a new vessels. You hardly see that the CNP areas are lost. Some CNP areas over here in the left eye. Now you look at the picture in bigger field, ultra wide field. You can see the lasers have been scattered. They have not been done adequately the way it should be done. You can see some neovascularization, and you do an ultra wide field angiogram. You can see these laser marks, but look at the ischemia which is extending much beyond the equator. So the standard teaching to us has been that in a diabetic case disease, it is a posterior pole disease. So the panretinal photocoagulation should extend about 1 to 2 disc diameter away from the vascular arcade only up to the equator. While this particular ultra wide field imaging now challenges that concept. You can see the extension of the ischemia right up to the equator, and so is the need in such cases of doing a panretinal photocoagulation, which is fill-in panretinal photocoagulation right up to the equator. Otherwise, these new vessels will not regress. Now, this is a case of a retinal vein occlusion, which was imaged elsewhere. And when you do it in an ultra wide field imaging, you can see again the same thing. In a previous angiogram, this was the area of weave, while here you can see the CNP's areas quite in periphery. So now your laser is going to be as big as this area, so you're not sure what you're trying to do. Now this is a patient who was referred to us for a case of, means he was advised an anti-VEGF injection for a macular edema. But when we did an ultra wide field OCT, we thought the sciatic cavities are extending much more beyond. So it's no longer simple macular edema. So it meant it was a case of retinoschisis. But why was this patient having a progressive loss of vision was a question which was unanswered. So we did an ultra wide field imaging for this, angiography for this. I will directly come to it. And you can see in this particular case, in the left eye, peripheral telangiectasia. So this is a case of a telangiectasia which was responsible for additional macular edema in a case of a retinoschisis. So how did it help me? This wide field imaging, I did a laser to this area as well. I needed it in a degenerative disorder like retinoschisis. You don't need an anti-VEGF, but here we did a laser for this telangiectasia and for taking a macular edema, and the patient responded. So this is how it changed my management in this particular patient. Now this is a case who was diagnosed to have retinal detachment, advised vitreous surgery, but I saw some fibrous tissue over here. So I was not happy. I looked into the other eye. I saw similar fibrous tissue in the other eye. I do an angiogram, wide field angiogram, and you can see for FEVR. So this is a bilateral FEVR. So ultra wide field imaging as well as angio helped me in picking a disease which would have landed up with a detachment later. So I could prevent this disease from coming in the other eye, or preventing a complication in the form of detachment in the other eye. And this is naturally the operated eye. This is 52 years old female who had this particular presentation diagnosed as an epiretinal membrane. But when you look at an ultrawide photograph, you can see there is some straightening of the blood vessels. So we did an wide field, imaging, and this we realized this again. It was a case of a FEVR and plus vitreomacular traction. So it needed a different management. Now this is 48 years male who had this particular patient diagnosed to have rot spots elsewhere. We did an angiogram for him, and you can see the peripheral shutdown. And same thing over here. Other eye also had a similar picture, and when we further investigated him, he had a bilateral carotid disease. So we prevented him from a morbidity or a absolutely mortal condition, which would, and this is how we helped in picking up a very morbid condition. This is another case. This is a patient who presented diagnosed Eales disease. We do an angiogram for this particular case, and you can see an half zone disease. Half zone disease is a terminology used in the cases of retinopathy of prematurity. This is for the first time we described a half zone disease. Again, he has a systemic disease in the form of bilateral carotid disease. Now this is interesting. 26 years old female girl who had healed choroiditis, but she had progressive loss of vision. We did an angiogram, ultra wide field angiogram, which we could see some ischemia in the periphery which needed treatment. Another case of a choroiditis with vitreous hemorrhage, where we could do ultra wide field imaging, and you can see that predominantly the vascular response in the periphery, which warranted a PRP, panretinal photocoagulation, rather a targeted laser only in the periphery, preserving the posterior pole. Now this is interesting. 25 years female diagnosed to have Eales disease with a combined retinal detachment. This is what the picture was. Naturally, she had a combined retinal detachment. But when we looked at the ultra-wide photograph, we thought we are seeing something abnormal in the periphery. So this is classic pruning of the blood vessels which have been described, which cannot be picked up on a standard photograph. Yeah. So we did an ultra-wide field angiogram, and this is what we see as a Takayasu's disease, which we made a diagnosis of. This is Takayasu's disease. So this better eye needed a treatment in the form of laser before taking her the eye with a combined retinal detachment. Now this 19 years female had a tricycle eye following a VR surgery, and father gave a history of having operated for glomus jugulare. Grandfather had some operation for brain tumor, and this is the better eye. I was not happy. Even to my eyes with 20 years experience, I thought this is a fundus which is normal. I still had thought I should do an angiogram, and when I do an ultra wide field angiogram, I can see multiple vascular tumors in the periphery, which I had missed it very easily. And so this is how it was a case of a von Hippel-Lindau. She needed a multiple treatments in the form of laser as well as cryo, triple freeze cryo. Father was asymptomatic. We got him screened, and look again what we see on our ultra wide field, multiple angiomas in his case. Similar thing again, a brother was asymptomatic, clinically normal. You see multiple angiomas. So this is how ultra wide field imaging can help you in such rare diseases. And then 1 year later, the brother had recurrence. Again, an ultra wide field angiogram was done, and we could pick up the recurrences and new lesions as well. Of course, we did certain studies for this, and we could pick up the lesion. And following this, now the next case, this is 38 years female with a vitiligo, and you can pick up the multiple, cysts like lesions. This is a case of a VKH, which we can pick up. Now we can do an ultra wide field imaging. Again, another case of a VKH, multiple blisters, which we can pick up here in an angiogram. This is another case, night blindness, diagnosed elsewhere as a case of CRAO. When we do an ultra wide field photograph, yes, it was a CRAO superimposed over a case of a retinitis pigmentosa. This premature baby thought to be a ROP, we could image. It is very difficult to image a baby. And while on a flying baby position, we did it, we could see the tumor as well as the secondaries in the vitreous cavity. Single image can make your life very easy. Even through a 4mm pupil, you could obtain. This is another triad of leukemia. You can see, rarely do you see all this triad of leukemia, that is a metastasis, infiltration, as well as a Roth spot. Again, a cover page. So this is a 16 years old guy who had a Berlin edema diagnosed elsewhere. We told him you have an horseshoe tear. He was not ready to accept. We did a wide field photograph, and then he was ready to undergo treatment. So such reluctant patients can be actually, they see, they believe. Now I will come directly to a few of the other cases where you see an horseshoe tear with a lattice degeneration. So finally, yeah, I'm just summing up. These are lattices which you can pick up. This is another case where you are seeing multiple decompression retinopathy. Fine, friends. It's a costly technology. No true color is always people who speak about against this particular wide field imaging. But there is a role, because we see only 1/3 of the retina on a standard wide field photograph, standard photograph, versus if you are seeing total retina, you understand and have a better look. Regarding the cost, what is the return on investment is the second question which I always get across. I always say these are the cover pages, some of the contributions of the from our group, from our hospital to the ophthalmology. These are the cover pages which was our contribution to the ophthalmology as well as eye, and few more publications by us. So thank you friends once more for this opportunity.
Thank you, Dr. Prashant, for the excellent presentation. I think we are almost finishing with time. Any quick questions or we'll sum up? Okay, I don't see any questions, so I think we'll sum up. Thank you all for your excellent presentations, and we hope to see you again next year. Thank you.
Thank you.